Anaphylaxis is one of those life-threatening disease processes that you have the power to reverse. A disease that can progress super rapidly, and if it does, without your quick action, will result in death. But the tools you have on your ambulance can save a life and lead to a really positive outcome for the patient. The question is, though, are you being aggressive enough with your anaphylaxis care? What does it mean to provide aggressive care in anaphylaxis? And when do you provide it? Join us in today's episode as we walk through the AMAX 4 framework with FlightBridge ED senior educator Bruce Hoffman.
Hear you on 8. You on 8. Okay, you're clear. Stand by for your base.
Welcome to EMS Cast, where we provide high-level education for you, the providers on the streets. Our episode today is brought to you by Frontline Optics. These sunglasses are designed specifically for first responders in mind. They know the job is tough on your gear, which is why they have a no questions asked replacement policy. If you ever scratch, break, or lose your sunglasses, they'll make it right and replace them. In addition, a portion of each purchase goes to the First Responders Children's Foundation. They're giving our listeners 15% off a sweet pair of new sunglasses if you just follow the link in the description and use the promo code EMSCAST15. That's promo code EMSCAST15. Today, we're going to be covering the AMAX 4 framework. AMAX 4 is not the run-of-the-mill allergic reaction or anaphylaxis. This is specifically for the unresponsive anaphylactic, the sick anaphylactic who has become so hypoxic or hypotensive that they've stopped perfusing their brain and will develop permanent anoxic brain injury within minutes if you do not do something to reverse it. This approach can be applied to the sick asthmatic as well, as these diseases have significant overlap not only in their pathophysiology of bronchoconstriction and treatment modalities, but also because there is significant overlap in the patient population who have both history of anaphylaxis and history of severe asthma. We actually did an episode on the sick asthmatic. That's episode 30. So go check that out if you want more of a deep dive on asthma. For today's episode, we're going to focus mainly on anaphylaxis. But again, the AMAX 4 framework can be used for both the sick unresponsive anaphylactic and the sick unresponsive asthmatic. For this episode, we're on site again at Fast 24 with Bruce Hoffman, who walked us through the tragic story of a real patient named Max, who needlessly lost his life, and his family, who have since made it their mission to improve patient outcomes from anaphylaxis worldwide by educating on the importance of aggressive care through a framework they call AMAX 4. Bruce is a critical care nurse and paramedic who is not only a senior educator at FlightBridgeED, but is also the program director and associate professor at Goodwin University and still works clinically with the Bay State Health Critical Care Transport Team. As I said in the beginning, the AMAX 4 approach is specifically for the sick anaphylactic who is now unresponsive. But before this 5-alarm fire unresponsive patient, there was a patient who was presumably awake and responding. Let's talk about them for just a second. First, we're going to zoom in a little, get deep into the trees, and review the definition and pathophysiology of anaphylaxis. And then once we have that basis, we're going to zoom back out, ditch the allergist definition of anaphylaxis, and learn a better, simpler way to see the forest through the trees. As a reminder, anaphylaxis is defined as, and this is the updated definition provided by the World Allergy Organization Anaphylaxis Committee in 2019, and they define it as a serious systemic hypersensitivity reaction that is usually rapid in onset and may cause death. Severe anaphylaxis is characterized by potentially life-threatening compromise in breathing and or the circulation and may occur without typical skin features or circulatory shock being present. They state that anaphylaxis is highly likely when one of the following two criteria are met. Those criteria are 1, an acute onset of an illness in minutes to several hours with involvement of the skin, mucosal tissue, or both. So in other words, generalized hives, itching, flushing, swollen lips, tongue, or uvula. One of those or both, plus one of the following: respiratory compromise, i.e. dyspnea, wheeze, stridor, hypoxemia, or a reduced blood pressure or associated symptoms of end-organ dysfunction, or severe gastrointestinal symptoms, meaning severe crampy abdominal pain or repetitive vomiting. The second criteria for diagnosis of anaphylaxis is an acute onset of hypotension or bronchospasm or laryngeal involvement after exposure to a known or highly probable allergen for that patient, even in the absence of typical skin involvement. For this article from 2019 that lays out this criteria and definition, you can go to the show notes and find the link to this paper to learn more of the rationale and what changes they made compared to the 2005 diagnostic criteria and definition. Now, how and why does anaphylaxis occur? Anaphylaxis is an IgE-mediated immune response. What does that mean? Antigens are foreign materials the body responds to when it comes in contact to them by forming antibodies against the antigen in order to prevent it from causing any harm. Unfortunately, in the setting of anaphylaxis, IgE antibodies have been inappropriately built up after an exposure to certain usually benign antigens. Most common examples being bee stings, latex, and foods such as peanuts, shellfish, milk, eggs, soy, etc. Upon re-exposure, so not the first exposure to the antigen, antibodies get built up. Second and subsequent exposures, the antibodies go haywire. And each subsequent exposure has the potential to be worse than the first because more and more IgE antibodies are potentially made. So on re-exposure to the antigen, the IgE that has been built up leads to an exaggerated response and rapid mass release of chemical mediators from basophils and mast cells. This mass release of chemical mediators includes histamine, tryptase, and others. These chemical mediators then trigger a cascade of events that produce metabolites like prostaglandin D, leukotrienes, and platelet activation factor. So let's break down what each one of these does and how that produces what we see in anaphylaxis. So histamine increases vascular permeability and vasodilation, leading to the swelling and hypoperfusion we see. Prostaglandin D functions as a bronchoconstrictor and also potentiates the peripheral vasodilation. And then finally, leukotrienes and platelet activation factor add to the bronchoconstriction and vascular permeability and also induce airway remodeling. As you can see, together, these lead to the swelling of the airway, bronchoconstriction of the lungs, and hypotension that we see in anaphylaxis. These are our vital ABCs, so it's no surprise that the management of anaphylaxis relies on addressing these EMS core principles, ABCs. This is our bread and butter, baby. And this is what we're going to fall back on when we recognize and treat these patients. The good news is that epinephrine reverses all of this. Epinephrine will decrease permeability, increase vascular squeeze and tone, and cause bronchodilation. The adult dose is 0.3 to 0.5 milligrams of 1-to-1 intramuscular epinephrine, and that can be repeated every 5 to 10 minutes until you see effect. Intramuscular is preferred because studies have shown it leads to a more rapid delivery and produces better outcomes than subcutaneous or intravenous delivery. If the patient is not improving after 2 doses of intramuscular epi, you may consider an IV push of 0.05 milligrams to 0.1 milligram of the 1 to 10 cardiac code dose epi. So that's going to be a 0.5 ml to 1 ml of the cardiac dose epi IV push, and followed by a drip if the symptoms are still persisting despite this. You can do adjunct therapy such as Benadryl, bronchodilators, steroids, but none of these are going to save the patient's life. Let me repeat this. Benadryl will not save the patient's life. Benadryl is an antihistaminergic but does not address the other chemical mediators and so will not and has never been shown to reverse anaphylaxis. It is merely a symptom adjunct. So Benadryl, bronchodilators, and steroids should not get in the way of administering epi and administering it aggressively. Epi is the true life-saving medication and should be your primary focus. Add in these others only when you've already treated appropriately with epinephrine. The question is then, when do you pull the trigger on giving epinephrine? Multiple studies have shown that providers often wait too long before giving epi, and the rapid benefit of epi in anaphylaxis far outweighs the risks of withholding the treatment. I think part of this is our tendency to just complicate and overthink this decision. So let's simplify this decision. First and foremost, forget the allergist definition that anaphylaxis is any allergic reaction that involves two or more systems. This is vague, somewhat subjective, and just not useful to me as an emergency provider. My emergency definition of anaphylaxis, i.e. when I'm reaching for epinephrine, is does it involve any of the ABCs? Is there airway involvement? Do they have any lip swelling, tongue swelling, posterior oropharyngeal swelling, or stridor? Is there any difficulty breathing? Are they having to use accessory muscles? Is there wheezing? And finally, are they hypotensive? It's as simple as that. An allergic reaction that involves the ABCs, this is your hard stop. Absolutely 1000% give epi, no questions asked. This is the principle. ABCs in anaphylaxis equals life threat, which equals aggressive anaphylactic treatment until the ABC symptoms are reversed. Now, don't get me wrong. A patient with an allergic reaction presenting with a rash and some GI upset, I am certainly taking seriously, and you should too. They are certainly getting close monitoring to assure that they don't develop any worsening symptoms. Do not blow these patients off. They are at risk for developing involvement of the ABCs, and we can't predict who will progress and who won't. If they do progress to involve the ABCs, they will require the same aggressive treatment. But in the absence of involvement of airway, breathing, or circulation, I am less quick to pull the trigger on epinephrine, and I will often start with Benadryl and frequent reevaluations. Caveat: if you have a patient with a known allergy, classic hives, and severe abdominal cramping or multiple episodes of vomiting, I will give this patient epi. It's going to make them feel a lot better, but just a little subjective nausea and rash, not so much. If you're familiar with the concept of thinking fast and slow, feel free to use your slow thinking brain here in this gray area and decide what's best. The most important point I can get across is hard stop, ABC involvement in the setting of an allergen exposure. The fast brain should be triggered to give epi without thinking twice. What about if their throat is a little itchy? Does this count as involving the airway? This again becomes a little more subjective, and this is again when I argue use your brain. Certainly, I don't want to discourage you from treating with IM epi in this situation. Many physicians I know will give epinephrine for a scratchy throat every time. But for me, it's a little more nuanced. If it's a 22-year-old with a history of an anaphylactic nut allergy who just accidentally ingested a nut containing product, I'm probably giving epi for that person, even if it's just a scratchy throat. This is a high-risk patient with a high-risk pre-test probability for severe anaphylaxis and a low risk for adverse event from epinephrine. Conversely, if it's a 66-year-old with a prior history of coronary artery disease and no known prior anaphylaxis with no known exposure but a rash and an itchy throat, this is maybe still a high-risk patient, but a lower pretest probability for severe anaphylaxis and a higher risk for adverse event from epi. I'm not giving epi, but I'm giving Benadryl, and I'm definitely monitoring closely for any objective signs of airway involvement or breathing or circulation. So if we're looking at the forest through the trees, remember, any allergic reaction with objective involvement of the ABCs, do not pass go, do not worry about cardiac risk factors, give the epi without a second thought. When in doubt, err on the side of treatment. But if it's subjective signs like a report of a scratchy throat and there's no objective oropharyngeal swelling, no stridor, their breathing is comfortable and their blood pressure is normal, then use your brain and assess their risk and pretest probability. And regardless of what you decide, monitor them very closely for progression of symptoms or ABC involvement. All right, let's say we've given 2 doses of IM epinephrine, but unfortunately, our patient's symptoms have worsened. They've now become unresponsive. Now what? Well, this is our 5-alarm fire, and you have arguably just 4 minutes to reverse this before a catastrophic outcome is likely. This is where the AMAX4 approach comes in. Let's go to Bruce Hoffman now at Fast 24 to learn what we need to do.
Bruce, thanks so much for coming on. That was just an amazing, heartfelt talk that you just gave, and such an important topic and a movement that I know has been stirred by tragedy, but hopefully will change and save many lives. So can you tell the listeners what we're talking about? What is AMAX4?
Absolutely. So AMAX4 was developed by Dr. Ben McKenzie and his wife Tamara. Their son in 2021 or 2022 died from anaphylaxis. His name was Max. He was 15 years old. Max was a healthy young boy on the cutting edge of life and ate some walnuts, to which he has a severe allergy. Max was at his grandma's house when this happened. He got 2 doses by EMS of IM epinephrine and then was transported to a very large level 1 trauma center. And over the course of 20 to 30 minutes, his airway was not controlled. There was no definitive airway management. There was some obvious gaps in the care that he received. And so Dr. Ben McKenzie, his dad, actually showed up at that hospital and ended up assisting with the surgical cricothyrotomy that was eventually done on Max. And Max passed away several weeks later, very devastating for their family. Instead of pursuing punition, the family really wanted to turn this into a proactive educational approach. And so that's exactly what they did with the development of AMAX4. AMAX4 is a framework or an algorithm that we can follow as critical care transport providers, really emergency medicine providers as well, that allows us to maximize all of the good things that are needed in anaphylactic and asthmatic patient management. Typically, AMAX4 is applied for the patient that is unresponsive and typically has had some kind of asthmatic or anaphylactic etiology that has caused it. And so to reverse their frank hypoxia and to stop the hypersensitivity or reaction that's happening, it prioritizes adrenaline or epinephrine. And that typically is given in 10 to 50 mic aliquots, literally every 30 seconds until you start to see improvement. The second piece is the M in AMAX4, and that stands for muscle relaxant. And that is usually combined with the next A, so AMAX4, and that is airway or definitive airway. So really looking at getting the patient intubated, whether it is through endotracheal tube intubation or whether it's through surgical cricothyrotomy, definitively securing that airway. And then the X just stands for really exaggerated or aggressive or extreme management of that patient's anaphylaxis or asthma. And that would include bronchodilation from both the parasympathetic and the sympathetic side. It talks about vasopressor therapy, epinephrine, norepi, vasopressin, methylene blue, fluid management. And then the last piece is basically to say, you know what, we need to make sure all of this is done within 4 minutes, because from the time a person goes unconscious, you have a saturation of around 40% that induces that. You have 4 minutes until there is hypoxic and irreversible brain injury or brain death.
Bruce just breezed through that mnemonic. We're going to break each one of those pieces down a little more further in just a second, but to review, AMAX4 stands for A, adrenaline, meaning epinephrine. For your unresponsive anaphylactic, you're going to be given epinephrine IV every 30 seconds until you reverse that involvement of airway, breathing, and circulation. M stands for muscle relaxant. If you have the capability to RSI, this is when you use it. You want your first attempt at the airway to be your best attempt, and that is going to be with the use of muscle relaxants. Which brings us to the next A, which is airway, definitive airway management. These patients are going to have such severe constriction that an iGel, King tube, supraglottic airway is just not going to give you enough peak pressures to overcome their peak pressures. And this airway needs to be secured quickly before hypoxic, irreversible brain injury sets in. So your best intubator gets one shot at putting an ET tube. And if they're unsuccessful, you're immediately moving to a surgical crike to obtain an airway, reverse the hypoxia, and prevent hypoxic brain injury. X stands for extreme care, extreme management of their hypoxia, their ventilation, extreme management with the medications, including the epinephrine we talked about every 30 seconds until you reverse the process, going big with your other adjuncts such as Benadryl, bronchodilators, steroids, vasopressor support to make sure that you're optimizing those ABCs that we talked about. Finally, 4 is 4 minutes. You want to get this done within 4 minutes. If that patient is unresponsive, their brain is not perfusing, it's not getting oxygen, and you need to reverse that within 4 minutes to prevent hypoxic permanent brain injury.
Okay. And so those are the 5 big pieces. And to highlight what you said, this is for the anaphylactic patient who's unresponsive. So likely has failed your typical approach, your IM epi. They're now unresponsive. You're sure this is anaphylaxis. Things are getting worse and you need to get really aggressive to turn it around before it's too late. And when we talk about those 10 to 50 microgram aliquots of epinephrine, that's actually IV epinephrine at that time.
It is actually, yeah. So they say, traditional medicine would say, if you have given 2 doses of intramuscular epinephrine and you have not seen an improvement or change, your next dose of epinephrine needs to be intravenously, and then it needs to stay intravenously until you see improvement.
Yeah. And then the big point with the muscle relaxant and using RSI if you can, paralyzing if you can, is because you really want your first shot to be your best shot. You likely only have 1 shot to get this airway.
Exactly. And that's exactly what the M stands for, is achieving muscle relaxation. And that's done through typically sedation and through paralysis. What we say is, if you have all your equipment there, you have everything set up, you're obviously going to have a BVM there. It's not ideal to put them right on a ventilator because of the extremely high intrathoracic pressures, but making sure all your equipment there, and then the best person in that room does the intubation and they get 1 shot at it. I know that's a little controversial, but then they're really encouraging people to move right to a surgical airway, and that will be your definitive management. That really should follow then extreme ventilatory support. These patients often have peak airway pressures north of 75 to 100 centimeters of water. So really a traditional BVM on the end of an endotracheal tube with obviously end-tidal CO2 is going to be the best way to both oxygenate and ventilate that patient.
And that's why an ET tube is going to be preferred over something like an LMA or iGel here.
Absolutely.
Because of those peak pressures, the amount of pressure you need to overcome to ventilate.
Yeah, absolutely. Anything that's supraglottic, you're probably not going to be able to maintain the mask, which will help to enhance ventilation in that patient.
What about the air trapping? We know that's going on.
Absolutely. So I think the benefit there is to get full exhalation. So you can either lower their respiratory rate to allow them to get full exhalation, really engage that. The other thing you can do is like lateral compression. So just like squeeze their chest and force exhalation out, because air trapping is going to be devastating, especially if they are already in arrest and they're already in a circulatory collapsing situation.
Yeah, kind of similar to our sick asthmatics.
Exactly. And I think that's why likely we've seen such an increase, especially in Australia. They have some of the highest rates of anaphylaxis and asthmatic arrests. I think that speaks to the therapy that we need to provide, and AMAC's 4 allows for that framework to be established.
Yeah. Yeah. And then the X, just as you said, is a reminder to get aggressive.
Very aggressive, extreme ventilatory management, extreme bronchodilation, extreme vasopressor therapy, and then really traditional anaphylaxis management, maximizing it. So whether that's bolus of steroids, magnesium, histamine blockade, you're really going at it very aggressively. But what maintains consistency is the dosing of IV epinephrine. I think Scott Weingart from MCRIT will tell you that instead of having to dilute epinephrine in like a push dose format, you could literally just give a half a cc of, IV cardiac epinephrine, and that might be the easiest way to do that. And you cycle that literally every 30 seconds to a minute until you start to see improvement.
Yeah. Talk more about your approach to vasopressor support in these patients.
Yeah, so I think that the go-to that I would call on is epinephrine. And that's exactly what I would do if I had a super sick anaphylactic asthmatic patient that was fully restricted. I would give likely a half a cc from a Bristojet, and I would give that probably every minute until I had a different assessment, whether that was through end-tidal CO2, whether that was looking at their hemodynamic status, or are they still wheezing? Are you getting any chest expansion and relaxation, or are you not hearing anything? Do you have like a silent chest and you're not moving any gas whatsoever? So I think all of those are kind of ways to maximize our therapy to get the best result for that patient.
Yeah, you just brought up another point that I think we might have skipped over with the adrenaline is you're going to give that every 30 seconds.
Exactly.
Again, getting aggressive, really aggressive to turn this around, because the last piece, 4 minutes, you only have 4 minutes until hypoxic brain death.
Exactly. And I think sometimes like waiting, if you were to wait 3 to 5 minutes, you're already outside of that window.
Yeah.
So getting very aggressive, it's almost kind of like micro dosing, right? But you're doing it very frequently to maintain the levels throughout the system so you can kind of uncouple or disable the anaphylactic progress and try to stifle it. What's hard is that it's such a devastating disease, but it's so reversible. We can do something about it.
Yeah.
And I think that's why Dr. McKenzie did what he did. And I really appreciate that, is not taking a punitive approach, but really an education approach, engaging and supporting, fortifying us as providers to be able to do the right thing.
Yeah. Well, thank you to the McKenzies for sharing their story and helping to educate the world. And thank you yourself for bringing this to our listeners and to this conference to help spread the word as well.
Absolutely. Thank you so much.
It's such a devastating disease, but it's reversible. We have the tools to reverse it. We can do something about this disease and prevent a death. To review, anaphylaxis, if it involves the ABCs, if there's an exposure to a known allergen, there's ABC involvement, we're given intramuscular epinephrine 0.3 to 0.5 milligrams and repeating that every 3 to 5 minutes until we see improvement in our ABCs. If after 2 doses of intramuscular epinephrine, we may consider an IV dose and or an epinephrine drip. If that anaphylactic patient goes unresponsive, this is when we get aggressive. We need to get aggressive and reverse this within 4 minutes, and we're going to use our AMAX4 framework. A, adrenaline, IV epinephrine every 30 seconds until you reverse this. M, muscle relaxers with RSI if you have it available. A, definitive airway management. Best intubator gets 1 shot at securing an endotracheal tube, and if not, you're moving to definitive management with a surgical airway. X is extreme. We need to get extreme and aggressive to reverse this within 4 minutes to prevent that hypoxic brain injury. Extreme ventilatory support to overcome those peak pressures. Extreme definitive airway management. Extreme epinephrine dosing. Extreme adjunct therapy with our other vasopressors, our steroids, our bronchodilators, our antihistaminergics such as Benadryl and others. And then 4 minutes until a hypoxic brain injury sets in. Get this all done within 4 minutes in your unresponsive, sick anaphylactic, or sick asthmatic. Thanks again to the McKenzie family for being vulnerable, and sharing this and educating the world. For more on the AMAX 4 movement and the story, you can check out our show notes. And thank you all for what you do, because what you do matters.